Hey guys, thanks for having me. My name's it's Luke. It's one of the other first four books of the Bible. Mark was the other one. I'll just give you guys your last talk, get you out of here early. I'm just sorry that I don't treat any solid tumors, but I definitely know who Dr. Lewis is, so it's awesome that he's up here, and I'm sorry that I have to follow that. And I'm sure every single talk you guys have had, everybody's preference to go over everything in 20 minutes is impossible, but I have the most, okay? No, I got to do everything blood-related here. I'll go as fast as I can. I'm just going to try and hit, I have no disclosure, so I got to do that. I just want to hit, I think, a few things that are practice. I think are practice changing or could become practice changing. There's so much that I could potentially cover. So I just wanted to pick some of those big things that I think is important. But before we dive in, I think one of the things that I have to talk about is CAR T, and then I'm going to talk about BiTE antibodies. For those of you that don't do any solid tumors, don't plug your ears and close your eyes and say, not my problem, because this technology is coming in every single tumor. They're in trials. We have in trial actively at Sarah Cannon. We have CAR T for prostate cancer, CAR T for hepatocellular. At Fred Hutch in Washington, they're doing CAR T for glioblastoma, breast cancer, all these things. So they're coming. So just basically, in brief, this brilliant young man back in the 90s figured out that you could transfect a T cell and insert DNA into it and make it express surface proteins that allow it to identify tumor cells. So an example here of our first kind of CAR T is that we transfect the T cell and make a chimeric antibody receptor that allows the T cell to recognize the tumor cell, lock onto it, and kill it by immune effect. And this has been a game changer, as have been the use of these what we call BiTE antibodies, or bispecific T cell engager antibodies, which this morning we just got another FDA approval for another BiTE antibody for diffuse large B-cell lymphoma called epcorafenib. And I didn't get that in this because it wasn't approved when I submitted my slide deck. So that just got approved this morning. But a BiTE antibody, some people say, is like a cheap version of a CAR T, which is an inaccurate statement. But what it does is it's an antibody that will cross-link a T cell and a tumor cell and kill it by immune effect. And these are very powerful therapies that I think we just all need to be aware of. They're triggering the immune system, and we have several different targets for that, and the ones I highlighted are ones we have FDA approval for. As of 11 o'clock this morning, we have FDA approval for a CD20-directed BiTE, so we're opening a CD7 CAR T at our institute too. So this is all coming, and it's coming for all types of tumors. The first few CAR T approvals are the ones I have listed here for B-cell lymphomas. That's brexucell, tisocell, lisocell, and axi-cell. They're all different sort of constructed CAR T products, all with different sort of side effects. And I just put this on this for completeness sake. But what we need to be careful about when using these therapies is a brisk response with the immune system, including cytokine release storm, which briefly is high fevers, can be low blood pressures, low oxygen, things of that nature, and need steroids or other medicines to reduce the side effects of those, as well as neurologic toxicity, where patients can have seizures, confusion, elevated intracranial pressures, and that we don't need to go through all of that now because we need to hit these big updates. So there were 3 really important clinical trials that were done in the last year looking at what if we use a CAR T sooner? The standard of care, as you guys know, is you get lymphoma, you get R-CHOP, you relapse, and then the standard has been more chemo and then a high-dose chemotherapy with autologous stem cell rescue. That's been the standard of care for a long time. But again, you're already showing something. You got a resistance to chemotherapy, so giving more chemotherapy, does that make sense? What if we do something different and attack it with the immune system when people relapse? And that's what these 3 landmark trials looked at, was using CAR T at that first relapse, and they randomized to CAR T versus the standard care of more chemotherapy and a stem cell transplant. And these 3 trials I have outlined here, the ZUMA-7, Transform, and Belinda study, and you can see at the very bottom the complete remission rates or complete response rates, the CR rates, looked to be superior, at least in the first 2 trials using axi-cel and the other trial using liso-cel. But the tisa-cel product, they didn't quite meet their primary endpoint. So these are game-changing studies because they've changed the standard of care. And I just really want to highlight, start becoming familiar with the use of CAR T, because it's not if they're coming to a clinic near you, it is when they are coming to a clinic near you and what type of target they're using. I'm sure eventually Dr. Lewis, and maybe he already does, have CAR Ts directed to colorectal malignancies at Intermountain Health, we'll see. But these things are all coming across the board. And so you got FDA approval for these products. The first, the axi-cel and liso-cel, you have FDA approval for first relapse, but the tisa-cel is still got to be after third relapse because their trial didn't meet their primary endpoint. This is another, I think, practice-changing trial. Just got FDA approval for this in the frontline setting, so the POLARIX study. As I told you just a minute ago, the standard has always been R-CHOP, right? You got diffuse large B-cell lymphoma, you get R-CHOP. Well, this was a randomized phase 3 study where they randomized people to either R-CHOP versus pola-CHP. So basically all they did is plucked out the vincristine, or the oncovin, which, sorry, I used the brand name, but put the polatuzumab in there for people, as you can see, 18 to 80 with previously untreated diffuse large B-cell lymphoma, with the primary endpoint to be progression-free survival at 24 months, which is a validated surrogate end marker for diffuse large B-cell lymphoma. And what they found is it did meet its primary endpoint, where Pola RCHP had a 24-month progression-free survival. Modest, only 6.5% better, but it still hit its primary endpoint. So you now have a randomized phase 3 study showing it's only modest, but a superior progression-free survival than R-CHOP. So keep this in mind. You might start seeing people get frontline Pola RCHP and R-CHOP goes away. We'll see. One of the things that I wanted to highlight is that overall survival has not changed yet, but as this data matures, that might change. Short follow-up. Toxicity between using polatuzumab and using Rituxan, standard R-CHOP is comparable. But one of the things I wanted to highlight is we're all kind of nerdy here, and we say, well, this is a forest plot, and anything of these things to the left on the forest plot favor the polatuzumab, and anything on the right favor R-CHOP. And you can see halfway, or 3/4 of the way down, it says cell of origin. The subtype of cells that have an activated B-cell subtype tend to benefit more. So people might say, well, I will give it frontline, but only in the activated B-cell subtype, which is a different subtype of the lymphoma. But remember that these trials are not powered to show that benefit. So I really think in an unselected across the board, you have a progression-free survival benefit of using polatuzumab over vincristine, so using Pola RCHP. So I've talked to some of the lymphoma doctors that do all this all day, which is what I do too, and most of them are leaning towards using this over R-CHOP. So R-CHOP might be going away. So really important to be aware of this. This is a practice-changing thing because R-CHOP's been the standard since, I won't make a side comment. So an update in mantle cell lymphoma, and this is important too, is that there was a randomized trial published in the New England Journal of Medicine where patients that were not eligible for transplant were randomized to get standard, which most people would use, bendamustine and Rituxan for mantle cell, versus bendamustine, Rituxan, and then ibrutinib, which I think many of you have seen if you've treated CLL. Ibrutinib is an oral drug that targets a specific signaling molecule in the CLL cells. And what they found was that there was a progression-free survival benefit of being on the triplet therapy. But that triplet therapy of ibrutinib was a little bit more toxic, and this did not translate to a survival benefit, but we saw progression-free survival, so it got published and such. But I want you to remember this trial was positive for something I'm going to tell you in a second. So the second big trial that came out was run out of Europe. This was a big topic of conversation at a hematology conference where the standard of care for mantle cell lymphoma has always been you get chemo and then you get a stem cell transplant. And they asked the question, can I do chemo, so arm A, chemo plus ibrutinib and a stem cell transplant, chemo plus ibrutinib and no transplant, or just old school chemo and a transplant like we normally do? What's better? And what they found was that the people that did anything ibrutinib did better, and the ibrutinib arm that didn't get a transplant did just as good as the arm that got a transplant. So this set this stage of like, hey, we don't have to do stem cell transplants for mantle cell anymore. And that's practice changing. Except this study was done in Europe, so the FDA is not going to approve frontline use of ibrutinib until that study is run stateside. The problem is this, and I'm sorry there's brand names on there, that the manufacturer for ibrutinib just announced this a few weeks ago. You can see on April 6th, that because of these sort of modest results for some of these trials, the FDA is asking them to withdraw their indication for using ibrutinib in mantle cell lymphoma. So this is going to be tricky to figure out what to do here. We don't know what the answer is, because I have data saying that if I can give you chemo and ibrutinib, I don't need to transplant you. That's nice. I don't want to, transplant, 5% of people just die from complications of a transplant. So if we can get rid of that, great. But our hands are tied stateside because this trial wasn't run in the States, and now we're losing our approval for ibrutinib for mantle cell. So this is going to be complicated to figure out what to do here. But I wanted you guys to be aware of this because this is a hot topic. CNS lymphoma, this was a big landmark trial that was presented at ASH this year, our hematology conference, where they said, look, can we stop doing transplants? For those of you that do a lot of breast cancer, as you know, we used to do a lot of stem cell transplants for breast cancer. We don't do that anymore because of trials like this, where you do a trial where you give people chemotherapy and consolidate them with a transplant, or you give chemotherapy and just give them a little bit more chemotherapy instead of doing a stem cell transplant. And that's what this trial was designed to do, to see, can we stop doing transplants for CNS lymphoma? And the answer is no, you can't, which was a little surprising to see because it feels like, being a transplanter myself, that we're rapidly putting ourselves out of business because the more trials that we do, the more we realize, hey, we don't need to do transplants for this, don't need to do transplants for that, and all that sort of thing. But this trial, if you look at the arm that got a stem cell transplant, their overall survival at 3 years, 86% versus 71%. I don't have the Kaplan-Meier survival curve on there, but you could drive a Mack truck through that thing. It's really important because any primary CNS lymphoma patient that you have, gotta get them to a transplant center for discussion. Maybe they're not a candidate for transplant, but the chemo that we use for a CNS lymphoma transplant is substantially easier than some of the other drugs we use for other transplants. So just shifting gears to hit all these game-changing things that can change practice. The Sequoia trial, you guys may have heard of this. This is a really nicely designed trial where they randomized patients to get bendamustine and Rituxan, and some of you might be like, we don't use chemo for CLL anymore, which is true. But when this trial was being designed and put through the FDA, that was something that we did. So this wasn't, some people argue about these straw man comparison arms where this is an unfair comparison, but at the time of the design of the trial, it was appropriate. And they randomized people to bendamustine and Rituxan or zanubrutinib, a new generation drug like ibrutinib that binds to Bruton tyrosine kinase and inhibits cellular proliferation. It's a pill. Or if you give standard chemo. And one of the nice things that they did, and they did this because we know this, is that people with a higher risk CLL called a deletion 17p CLL, if you give them chemotherapy, you kind of select out the aggressive clones, and actually their prognosis is worse. So they knew that, and they self-selected those people out, so they did not get chemo. But long story short, what they found is that zanubrutinib was substantially superior to bendamustine and Rituxan. And you can use frontline zanubrutinib now. Many of us still reach for ibrutinib, which is totally reasonable in the standard of care, or use another drug called venetoclax. That's very reasonable too. But I set the stage for this trial, and excuse me, the toxicity for the zanubrutinib is much, much better than traditional chemoimmunotherapy. But I set the stage for that because this is an important study, the Alpine study. So that first study, the Sequoia study, was looking at frontline zanubrutinib versus chemotherapy. This is looking at relapse CLL in randomizing patients to zanubrutinib or ibrutinib, or Imbruvica, which is the brand name, which, again, I apologize for using that, but just so we're all on the same page. And what did they find? Well, there was a progression-free survival to zanubrutinib. So zanubrutinib looked superior to ibrutinib. Is it superior to ibrutinib in the frontline setting? I don't know. We don't have that data. But it's superior to ibrutinib in the relapsed setting. So if you have a relapsed patient with CLL that you were planning to do ibrutinib on, I would reference this Alpine trial and see if your patient would be eligible for zanubrutinib, because that's a big change there, a different drug than we normally use. It also looks superior in patients with the 17p or p53 mutated, very high-risk CLL patients. That signal of benefit still persisted there, so that's something that we really need to watch for. And the toxicity between these two drugs is very comparable. Okay, jumping over into acute myeloid leukemia. This was such an important trial that they still haven't published it, but they presented it at ASH, and so I still wanted to talk about it, even though we don't have the formal publication of this trial, because this was a plenary session at ASH. And so this is the ASAP trial for acute myelogenous leukemia. And basically what the trial is that they wanted to see do we have to flog our patients with acute leukemia with cycle after cycle after cycle of chemotherapy to get them into remission and then do a stem cell transplant on them? Or can we just give them a little low-dose chemotherapy, watch them, and then blast them with chemotherapy one time for the transplant? Do we really need to flog these people? Well, it's important because as before December of 2022, we would all just be emphatic that you need a patient to be in a complete remission before thinking about doing a stem cell transplant. You're crazy for trying to transplant someone with active disease. And to the credit of these people in this study, they said, well, hold on, let's see if that's true. So this was a randomized trial where patients kind of get enrolled in this. If they're stable, can we just watch them? If they're not stable, can we give them just some very low-dose chemotherapy and then take them to transplant, versus doing the standard of care, aggressive high-dose chemotherapy and then transplant in remission? And what they found is that there was no difference in disease-free survival from blasting these people with chemotherapy, but you can see that the grade 3 or higher toxicities to the control arm or the standard of care arm, was much, 64% versus 23%. People got out of the hospital faster, people engrafted faster, better quality of life, all of the things. And I do think this could change practice, but I need a full manuscript. So keep an eye out for the ASAP trial if you guys treat leukemia, because that could change the way that we do things. So finishing up here, because I got 1 minute and 37 seconds. I know you guys are probably counting it down too, ready to get out of here. So the Majestic trial, because it's studying teclistamab, these drug companies need to calm down with how they name trials, but the Majestic, so ridiculous, trial is that BiTE antibody that I talked to you guys about, where it's that antibody that grabs onto the immune cell, grabs onto the myeloma cell, pulls them into contact with each other, and you kill the myeloma or disease of choice with immune effect. And this was a clinical trial where patients that had over 3 lines of therapy were enrolled on a single-arm study. You go through 3 lines of therapy with myeloma, you're starting to scrape the bottom of the barrel. Not a lot of good options. That's when we start doing second transplants and stuff like that. And this study showed, so there's the design of the trial. There was step-up dosing. And you can see the composite overall, very good partial response rates are better, 58%, with 21% of them having a stringent complete response. And this is heavily pretreated patients. So this got an FDA label despite it not having a randomized trial. We use a lot of teclistamab. I would strongly, if you guys look at getting this in your clinic, this is a very, very powerful drug, but it comes with a lot of those side effects that we've talked about. So these are some of the big practice-changing things. And the other thing with this trial is that this is a waterfall plot showing durability of response, and you probably can't see it on there, but out of all these patients, there's only about 6 of them that have progressed. The rest of them remain in response at the time of this publication. So a lot of CRS toxicity that I talked to you guys about, and in the interest of time, I will stop there, and there's my little crew. So any questions with that, since we're out of time? Okay.
No questions?
My name and, well, it's gone now, but my name and phone number are on there. If you guys have any just complex heme cases or anything in your clinic, and it's a whirlwind of information to go through in 20 minutes, but all of those things are practice changing. Just at the end of the day, shoot me a text, drop me an email, and happy to just advise or give my recs, whatever, however we can do to help. Okay, thanks guys.
Thank you.